The final chapter, psychological disorders. So, drugs. Drugs. Remember drugs? We talked about drugs a little while ago when we were talking about the synapse, but they are back. So, a lot of drugs are derived from plants. So, for example, the nicotine in tobacco, marijuana, and THC, or you have the opium poppy, right? A lot of people will say, "Oh, if it's natural, it's good for you." Not necessarily true, right? When it comes to the brain, chemicals, whether they are things that you're plucking out of the ground or they are things that are being manufactured in a lab, they're going through the same pathways and making the same effects happen. So there's not really any difference between something that is manufactured versus something that is grown. Now, there are two types of drugs that we're going to talk about right now. One is an agonist, and that is a drug that blocks the neurotransmitter. Then we have agonists that mimic the effect or increase the effect of a specific neurotransmitter. So, if you remember our receptor sites, an agonist will go in and block the receptor site so that the neurotransmitter can't go in. An agonist is going to, so you have the normal neurotransmitters, but if you have an agonist, it will go into the synapse and mimic the effect of the neurotransmitter. So it's like you have more of that neurotransmitter available. So it's mimicking that effect. When it comes to a drug's action in the brain, there are a couple things that we need to be aware of. One is the drug's affinity for a receptor. That is a measure of the drug's tendency to bind to it, right? So just because there's a receptor here and there's a neurotransmitter here, doesn't necessarily mean that it's going to bind in the receptor. Think about having two friends that are single, right? You're just like, oh, well, they're both single, so of course they'd want to bind to one another. No, no, no. They have to have a strong affinity towards one another. They have to have a few things in common. So that affinity is going to range from strong to weak. Then we have efficacy. So that's a tendency to activate the receptor. So just because it binds, right, doesn't mean that it's going to, have any activation. Doesn't mean that anything's going to continue down the neuron. So those two single friends go on a date, and you're like, well, done. They're in a relationship now. No, if the efficacy of them is referring to the fact that, like, well, is anything going to happen? Will the magic happen? So the effectiveness and side effects of a drug are going to vary from one person to another because no one's brains are the same. So some people might have more of a certain receptor, and that's going to vary from person to person. And based off of the amount of receptors that they have available, that's going to affect their response to a specific drug. So, a lot of people might say that drugs are bad, right? Don't even try drugs. Once you try, you're going to get hooked. Now, when it comes to things like opioids, which are very addicting, you have to be careful because even if you don't have a generally addictive personality, your body is going to get hooked. But people in general differ in their predisposition to alcohol or drug abuse, right? Some people might just have a glass of wine a day with dinner, and that's all they do, and that's not alcohol abuse. Some people start drinking and they can't stop drinking. So we have our own predispositions. So aspects of our brain's functioning and behavior are often very clear at the start because people have, or addiction is very heritable. So there are certain traits that we might have that lead us to be more likely to abuse or be addicted to drugs. But not everybody develops addiction. So when we look at twin studies, we can see that there is a strong influence of genes on our vulnerability to alcohol and drugs. If a family member is an addict, you are very likely to have addictive tendencies. So we've identified many addiction-linked genes, but each of them have a small effect. So they all affect the probability of substance use. Uh, the more of them you have, the more likely, but also environment, as with everything else, is important. So let's say you have the genetic disposition for alcoholism, right, or any addiction. But from a very early age, you learn very healthy coping strategies before you even have your first drink. So whenever you feel overwhelmed, you learn how to balance out your stress. You have people who you can talk to, right? You have very healthy coping mechanisms. By the time you try alcohol, you might not need to rely on it to make you feel better because you already have a way of moderating your emotions, right? If you have unhealthy coping mechanisms already and then you try alcohol and it makes you feel a lot better, well, then you're going to depend on it more. So some people have a gene for producing uh, uh, acetyl. I literally just learned the pronunciation of it. So I'm going to pause the recording, practice it again, and impress you by how good I am at pronouncing this. Acetaldehyde dehydrogenase. Acetaldehyde dehydrogenase. It's so easy. When you're just hanging out with your boys and you're sipping on that acetaldehyde dehydrogenase. So some people have a gene that produces less acetaldehyde dehydrogenase, which metabolizes acetaldehyde, which is a byproduct of alcohol, more slowly. People who have that gene tend to drink less and have fewer problems with alcohol abuse. The reason for this is you get a lot of the negative symptoms of drinking alcohol much more quickly. Sometimes you'll see like flushing of the skin, so this redness or glow, as some people might describe it. And so, because you get it so immediately early on into drinking, you're less likely to abuse alcohol. So, because of that gene and how common it is in countries like Japan and China, alcoholism is very rare. So, back in the day, in 1998, it was pretty common to see a alcohol vending cart until 2000 when they were banned, unfortunately. So again, environment is very important. Your prenatal environment contributes to risks for alcoholism. So even before you're out and about in the world, that is important. Also, your childhood environment is critical. So the more supervision that you have from your parents or family members is going to decrease your likelihood of developing the impulsive behavior that will lead to abuse. So alcoholics that develop problems before the age of 25 tend to have a family history and a genetic predisposition, which leads to that rapid onset of problems. So you're going to see it happen very quickly. So, some fun research findings. If you are the son of an alcoholic, you are going to more than likely show a lower than average intoxication after drinking a moderate amount of alcohol. So, you can drink more and get less drunk. Lower levels of intoxication might influence you to keep drinking. Also, having a cat meow at you while you're trying to record a lecture is going to influence you to keep drinking. So by slide 50, I will be hammered. But lower levels of intoxication are going to influence you to keep drinking because you're not getting those negative side effects, right? Your probability of developing alcoholism if your parents have it is greater than 60%. So it's highly heritable. It also decreases stress for most people. If you've ever, had like a stressful day and gone out drinking with friends, after a drink or two, you feel a little bit better, right? But when you are the child of an alcoholic, especially the son of an alcoholic, the amount of stress relief that you get from alcohol is even greater, meaning that it's more likely that you're going to lean on it as a coping mechanism. So, one way to test this heritability is to compare people who are sons of alcoholic fathers to young men with no alcoholic relatives. If they're drinking the same amount, so maybe they're cool college kids and they're going to parties all the time and doing beer pong and shots and all those cool kid things, right? If they're all behaving the same way, but some of them turn out to be alcoholics, but others don't, and the only difference between them is that some of them have alcoholic parents and some of them don't, then we can assume that it's very likely that parent, that genetic predisposition is present. So the fact that they had an alcoholic relative was important in their development of later alcoholism. All drugs affect your brain differently. They're going to affect different receptor sites. Some affect just one, some affect multiple. The effects that occur while the drug is in your brain are going to differ from the effects that occur when your brain is experiencing withdrawal or the effects that are responsible for the cravings for that drug. So, when you're trying to alleviate drug abuse, you have to consider a variety of mechanisms in the brain. So James Olds and Peter Milner, as you might guess, were playing around with rat brains. Uh, while stimulating different parts of the brain, they hit the septum of the brain, which caused the rats to respond favorably. So the rats, at a certain point, they kept on playing around with the septum, and they learned that the rats would push a lever to produce self stimulation to that same area. Because of that, they were like, oh, there must be something with this area. It's related to the feeling of reward. So the nucleus accumbens is central to reinforcing experiences, whatever experience we might be experiencing. So if I watch a show and I'm like, oh, this is a good show, nucleus accumbens. If I go on a date and I get a little kiss on the cheek because that's that's what guys are. All guys want. They just want those cheek kisses, right? And I'm like, ooh, that's nice. Nucleus accumbens. I'm playing video games and I get an accomplishment. Nucleus accumbens. It reinforces all types of behavior. When you're dealing with addictive drugs, they're releasing dopamine and norepinephrine in this area, the nucleus accumbens. So, as mentioned, many different experiences can release dopamine in the nucleus accumbens: sexual excitement, music, the taste of sugar, imagining something pleasant. So, if you're just like, ooh, end of the semester, oh, all my finals are done. I got a 4.0 this semester. Oh, it's so good. Nucleus accumbens, and also gambling and video game playing, nucleus accumbens. Modern games are made to be more addictive because we realize that if you give people little reinforcers here and there, then they're going to play for longer. If you play video games and you're familiar with games that have loot boxes or loot crates, right? You're craving that release of dopamine because you don't know which box is going to give you that super epic loot. You don't know, but when you get it, oh, it's such a great high, and you're constantly chasing that high. So, dopamine release is essential for all addictions, and or we might assume that it's essential for all addictions and all substance abuse, but not so fast. It contributes to reinforcement. Sometimes I really love how the textbook makes their slides not so fast. You thought one thing, well, you better not think that one thing. Dopamine does contribute to reinforcement, but it's not as central to reinforcement as we previously believed. So it's part of it, but as we have learned during this entire semester, you can't explain one function by just one thing. So let's say you're doing some cocaine, or maybe you're just having a Coca-Cola because it does have sugar in it, a Mexican Coke. So actual sugar, not just that high fructose corn syrup. So it's activating this pathway. So axons from the nucleus accumbens are going into your prefrontal cortex. Here's a little nucleus accumbens here, and your brain is going, yes, we like this. Let us base our life around getting more of this substance. Let's talk about cravings. Right now, maybe you haven't eaten yet, and oh, it'd be great. I don't know what you like. Is it Oreos? Is it Taco Bell? Is it carne con papa? Do you like a little carne con papa? Man, I haven't had carne con papa in a long time. I would I'm not gonna say that I would kill for some carne con papa, but I would like maybe punch somebody like in the face for some carne con papa. But those cravings, right? That insistent search for an activity. This is just a distinctive feature of addictions. So some of us might have the feeling of like, uh, oh man, you know what I haven't had in a while? Taco Bell. That would be great, right? Uh, but sometimes that like feeling is like, oh, I need it or else I'm gonna die, right? You're in class maybe and you're just thinking about it. It's all you can think about. You look at your professor and they become nachos, or one of those freezy strawberry things that they have. I can't remember what they're called, but they're delicious. So uh, the thing about cravings is even if you haven't done something for a very long period of time, there are cues that can trigger that craving, which is why sometimes people will be clean off of like alcohol or some other drug for a long period of time, but then they just get those cravings again, right? And it could be anything. It could be a song, it could be seeing a friend who you haven't seen in a while, it could be driving by the place that you used to do that drug. So cravings can be very powerful. When we look at rats, surprise, surprise, repeated exposure to anything that's addictive is going to alter receptors to become more responsive to the addictive substance. So not only do we crave it, but our brains are more responsive to it and they become less responsive to other things. So other things don't make us as excited as that one thing does. So, as you might know from, I'm just going to assume that all of you are drug addicts. The more you have of something, the less effect you get from doing it. So, if I have a cup of coffee, and maybe I don't drink coffee very often, right? I have that one cup of coffee, and oh boy, I am wired. I am jittery. I'm talking a million miles a minute, right? But if I have that cup of coffee every day, then over time, one cup of coffee isn't really going to affect me. That's what's called tolerance. It's a decrease in the effect of a drug as your addiction develops. So, this is a learned behavior to a large extent. And if I were to take a long break from coffee, I didn't have coffee for 3 months, then that next cup of coffee, boo, right there, right? It's really going to make me have that same effect again. I'm going to be jittery. I'm going to be talking really fast. I'm going to have a whole bunch of energy, right? That would be because I've lost that tolerance. Withdrawal is our body's reaction to the absence of a drug. So if you are like me, addicted to caffeine, and maybe you wake up and you're rushing out of the house and you don't have time to get any caffeine in you, and then you get that headache. Oh, that terrible headache, right? That's your body's reaction to not having caffeine. So some one theory of addiction is that we continue doing the drug so that we don't have to deal with withdrawal symptoms. There's another hypothesis related to addiction, which is just addiction is used to cope with a stress, right? So I maybe caffeine, like at the beginning of the day, really calms me down. Something about having a warm cup of Joe just makes me feel like everything is right in the world. So I'm usually very stressed, but having caffeine lowers my stress. So every time I'm feeling a little stressed, I take caffeine and it lowers my stress. So the next day, I'm starting to feel stressed again. I have caffeine, lowers my stress. The next day, I don't even have to start feeling stressed. I'm going to have caffeine to keep my stress low, right? This could be alcohol, this could be heroin, this could be anything. So we use it to deal with our problems. That's called self-medication. When you look at rats, if a rat receives an addictive drug during their withdrawal period, it can be a very powerful experience. So that relief uh, can be associated with reinforcing the drug. Some people, when it comes to addiction, are able to decrease their use or quit on their own. So sometimes you just have that moment of like, I'm really doing too much. I need to pull back, right? So I'm drinking 3 rock stars a day, sometimes four. This is not good. This doesn't feel good. So maybe let me just wean myself off. I'll only do two a day, even if I feel a little bit tired. Then in maybe a month or so, I'll try to do just two a day, and then for the rest of my life, let me just do one if I need one, right? So some people are able to decrease their use on their own. Some people might use Alcoholics Anonymous or a similar group like Narcotics Anonymous. There's also cognitive behavioral therapy, where you're looking at the thoughts behind your specific use and focusing on the actual behaviors. So you're also learning to reward yourself for remaining drug free. There are also medications. So different drugs have different medications that allow you to condition yourself to not enjoy the drug. One easy one is just the nicotine patch, right? So you're switching the addiction slightly. You get the nicotine, so the cigarette would be less enjoyable because our bodies are very responsive to nicotine. So if I have the nicotine, I'm no longer craving the cigarette. So at the very least, I'm saving my lungs. There's also antabuse, which if you take it and then you drink, you're going to get violently ill. So drinking becomes associated with being violently ill, so you're less likely to drink in the future. Totally forgot that the next slide is about antabuse. So yes, disulfiram. If you drink it, or if you take disulfiram and then drink alcohol, you will feel very sick. So you're learning to be averse. It's learned aversive conditioning. Uh, it's not the most popular treatment because one issue is that you have to continue taking the antabuse. And if you know anything about people and medication, people have a very hard time complying with medication. So that is one of the biggest issues in medicine, telling people to take something twice a day and them not doing it. So we also have a lot naloxone and naltrexone, and those block opiate receptors and decrease the pleasure from alcohol. So you're not going to feel good. You're not going to feel terrible, but you're not going to feel great when you're drinking. So if you uh, uh, anything that can change how good you feel when you take a drug is going to affect your continued use of the drug, but also it's dependent on the drug user's motivation to quit. For opiates like heroin and morphine, we have methadone. It's great because it activates the same brain receptors and produces the same effects, but it's significantly less than what you would get. So you're reducing the rush that you would get from the drug. You're reducing the withdrawal symptoms because you're still getting a drug, but you are reducing the person's need to take heroin or morphine because they're getting the same or similar effects. You also have alternatives, these two. Now let's talk about depression. We talked about addiction, and now you're probably feeling a little bit depressed. So some of the symptoms of major depressive disorder or major depression are that you feel sad and helpless most of the day, every day, for long periods of time. You don't enjoy anything, and you can't really imagine enjoying anything. This is called anhedonia, so it's a loss of pleasure. So maybe you love playing guitar, or maybe you love listening to music, and that's usually the thing that brings you joy. But when you do it now, you're not getting that same feeling of joy. You might also feel tired all the time. You might feel worthless. There might be thoughts of suicide or dying. You might have trouble sleeping. You might also have issues with your appetite, either increased appetite or decreased appetite. There might also be associated cognitive problems, not really motivated to do anything. You're feeling with feelings of withdrawal, so you just don't want to go out and do anything. There might be impaired memory, issues with concentration, and sometimes even an impaired sense of smell. When you see somebody who is depressed, it is apparent in their face, it is apparent in their behaviors, it can come across in their tone. So if you're used to me talking like this, hey, I'm Professor Thompson, this is me, this is how I talk. Um, Sometimes when people are feeling very depressed, they might um, their voice might get a little quieter. There's like a kind of like weakness and flatness in the expression. Um, there's sometimes a slowness in cognition because um, depression just doesn't affect kind of like your mood. Sometimes it's also sorry. Sometimes it's also affecting your um, I'm sorry, cognition. So you once you are more aware of like what the symptoms of depression are, it becomes easier to spot even the little things. It's not just necessarily feeling sad. Sometimes people feel nothing. Um, so that could be what um, what depression could sound like. So as kind of touched on before, the absence of happiness is actually a more reliable symptom of a depression than increased sadness. So kind of just feeling blah, like nothing is going on, right? Not really feeling anything. It can affect 5% of adults within a given year, but it has a 10% lifetime prevalence. So it's pretty likely that you or someone that you know will experience it. Some people suffer it for long periods of time, but it's more common for people to have periodic episodes. So it comes and goes. So there is a moderate degree of heritability, but not one. There's not one gene that's the depression gene. People who have early onset depression are more likely to have relatives that have had depression or currently have depression, as well as relatives with anxiety disorders, neuroticism, ADHD, OCD, IBS, irritable bowel syndrome, and migraine headaches. Late onset depression, so if it comes after the age of 45, is linked to relatives who have issues with their circulatory system. So the working hypothesis for depression is that the effect of the gene is going to vary with the environment. So it's not just genetics, it's not just the environment, it is a combination of both of them. So some of the evidence to support this is as follows. So if you are a young adult and you have the short form of the serotonin transporter gene, if you experience if you experience something stressful, a major stress, then that's going to increase your probability of developing depression. The long form of the gene is going to make you less susceptible to stressful events. If you're receiving both, then it's a moderate risk. So that short form gene is going to likely increase the reaction that you have to stressful events, especially if they're occurring in your childhood. So here we can see how the environment and the genes work together. So if you have no stressful life events, then your probability for developing a depressive episode is pretty low, around 10%, right? Same if you just have one. Around two, we start to see a difference. Maybe not a significant difference, but a bit of a difference. But around three, and especially at four, we can see that there is a big difference in that expression of the gene. So if you have two of the short genes, then you have the highest risk. If you have two of the long genes, you have the lowest risk. If you have one of each, you have a moderate risk. So when you're looking at depression in the brain, you might notice that there's decreased activity in the left prefrontal cortex, but increased activity in the right prefrontal cortex. Interestingly enough, when asked to do a verbal task, most people will gaze to the right, but people with depression tend to gaze to the left. So now everybody's going to be paying attention to where you look when somebody asks you something verbal. So name three words that rhyme with cat. And then you think, I looked right. Okay, I'm happy. I'm actually happy. Oh, woo. There are a variety of drugs that are going to help with depression. Some of the ones that you might hear about are tricyclics, selective serotonin reuptake inhibitors. Sometimes you have serotonin and norepinephrine reuptake inhibitors, SNRIs, MAOIs, monoamine oxidase inhibitors, and atypical antidepressants. So let's talk about tricyclics. Tricyclics block the transporter proteins that are going to help reabsorb serotonin, dopamine, and norepinephrine into the presynaptic neuron after release. So they're slowing down that reuptake process for those three neurotransmitters. They also block histamine receptors, acetylcholine receptors, and certain sodium channels. Some of the side effects of tricyclics include drowsiness, dry mouth, difficulty urinating, and heart irregularities. In case you ever wondered how reuptake works, you have a little serotonin transport right here. It grabs the serotonin and then it just flips around and then puts the serotonin back in the presynaptic cell. What the tricyclics will do is lock this in place so this flipping mechanism doesn't happen, so the serotonin will stay in the synapse. Tricyclics, SSRIs, and SNRIs are going to work on this reuptake process, and they're going to block reuptake, right? That's why they're called selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors. They're blocking that reuptake process. MAOIs, or monoamine oxidase inhibitors, block the enzyme monoamine oxidase, which breaks down our neurotransmitters into inactive substances. So if you're blocking the breakdown of neurotransmitters, more are going to be available to release into the synapse. SSRIs are the most common antidepressant. They block the reuptake of the neurotransmitter serotonin. They are selective because they only focus on serotonin, unlike tricyclics, which focus on three neurotransmitters. Some examples are fluoxetine, Prozac, Zoloft, Luvox, Celexa, Paxil. So these are the brand names. These are the generic names. So these are pretty common. They work in a similar fashion to tricyclics, as you've seen, but they are specific only to the neurotransmitter serotonin. And also, if we're talking about SNRIs, those focus just on serotonin and norepinephrine. I gave you a little preview because I never want to surprise you. Oh, another antidepressant, right? So we have our serotonin norepinephrine reuptake inhibitors. So Cymbalta, Effexor, they block the reuptake of serotonin and norepinephrine. But unlike other depressants, SNRIs actually can improve certain aspects of memory. So you feel a little bit better and your memory improves. Any guesses to why your memory improves? Do you remember us talking about a certain neurotransmitter and its effect on memory? Hmm? 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 Then we have MAOIs, or monoamine oxidase inhibitors. Remember, monoamine oxidase is going to break down serotonin. It also breaks down catecholamines into an active form. So if MAO is doing its job, then you're going to have less of that available. But by blocking it, we're able to release more neurotransmitters into the synapse. So we only use them if other antidepressants are not effective. Um, you have to be careful with your diet because depending on what you eat, that can lead to high blood pressure, which isn't a good side effect. You want your blood pressure to be normal. Then we have atypical antidepressant drugs. These are a catch-all for all other drugs that can lower your depression. An example of this is Wellbutrin, which is going to inhibit the reuptake of dopamine and norepinephrine to some extent, but not serotonin. So all the cool drug kids might have heard of ketamine as a potential treatment for depression. Ketamine antagonizes your NMDA type glutamate receptors, and it produces very quick antidepressant effects in people who don't respond to other medications. Now, we don't prescribe ketamine because it can produce delusions and hallucinations, so you treat the depression, but you're getting psychotic symptoms, which isn't great. But by studying ketamine and its effect, we might be able to find a similar type of chemical that can treat depression quickly without those same side effects. Some people use St. John's wort. It is a herb that is often used as an over-the-counter treatment for depression. It's a supplement, so it's not regulated by the FDA, so it hasn't been studied or tested well. But its effectiveness is about the same as any standard antidepressant. One side effect is that it increases the production of a liver enzyme that decreases the effectiveness of other medications. So if you've ever wondered why when you go to the doctor, they ask you for a list of all medications that you are taking, if they are smart, they'll also ask you to list herbal supplements. Well, if you're taking St. John's wort over the counter and you don't list it, and you're taking a new medication to treat some, disorder or disease that you might have, and they don't know that you're taking St. John's wort, the treatment might not be as effective. So it's important to always tell your doctor or your pharmacologist that you are taking other things, because you might not think of it as a big deal, but it could affect your body's ability to respond to a different medicine. So the effectiveness of antidepressants is a bit confusing. So most people with depression have normal levels of neurotransmitters. Decreasing serotonin in control groups doesn't actually provoke depression. So we're looking at SSRIs and we're going like, okay, well, it's making more serotonin available, but if more serotonin cures depression, less serotonin should be related to depression, but that doesn't seem to be the case. Also, drugs like SSRIs affect the neurotransmitters pretty quickly, minutes to hours, but the results in improving mood with any type of antidepressant can take weeks, sometimes months. So if the drugs are affecting the synapses pretty immediately, but it takes a while to see the effects on depression, then what's causing the depression to get better? So people with depression have lower than average brain-derived neurotrophic factor, BDNF. And this is important for understanding synaptic plasticity, just basically how much the brain is going to change. So people with depression are going to show a smaller than average hippocampus, impairments in learning, because, hippocampus, and reduced production of hippocampal neurons. Prolonged use of antidepressants will increase BDNF. So it's going to make the brain more open to change. The proliferation of new neurons in the hippocampus is important when we're looking at the effects of antidepressants, but it doesn't seem to be completely tied to BDNF. And one thing to note is that studies of antidepressants have shown that it might not actually be helpful for some types of depression. When you're looking at mild, very mild depression, or even some like moderate forms of depression, it tends to not, we don't see the same efficacy of an antidepressant drug that we would see if we were dealing with severe depression. So antidepressants for mild depression don't really seem to do better than the placebo. So here's a scatter plot. The triangles are the drug, bigger the triangle, more people who fit that criteria. So here would be a lot of people who had very mild depression, who saw no improvement. But right here, here are some people with maybe this is just like one person with moderate depression who saw slight improvement. So the triangles are the drug, the blue circles are placebo, and you can see that over time, placebo got less effective. Sorry, not over time, over the severity. And over as severity increased, the drug becomes more effective to a point. There's a very slight drop off. This area right here is the area where the difference between the two is statistically significant. So these slight differences could just be due to chance. It could just be due to the sample. So that difference that we see might not be as significant, but in this area, we can see that it's very unlikely that this difference where the drug is more effective than the placebo is due to chance. So a few things that we can gather from this, right? One, severity, once we're in this high level, the drug actually does create a clinically significant difference where the difference between not having the drug and having the drug are going to be felt by the participants, right? This difference is not clinically significant because look at how small an improvement that is, right? So if you have been playing basketball for years and then you get 2% better at playing basketball, you probably won't notice that, right? It's very hard to feel the difference of 2%. If you got 50% better, right, that would be a clinically significant difference. So with this, right, it's worth it because the participants can actually feel the difference. It's not just a measured difference from the statistics. But then on the other hand, right, when you're in this moderate to mild level of severity, then you're not really getting any benefit from having an antidepressant. It's not clinically significant. Even though here you'll feel or you'd be able to measure the difference between the groups, it's not significant enough where you would feel it if you were the person taking the antidepressant. So there are alternatives to drugs. One, we have cognitive behavioral therapy, which is equally effective for all levels of depression. And it also shows increased metabolism in the same brain areas as antidepressants. And it's more likely to reduce relapse months or years later. The effects of CBT affect you in the long run because not only are you gaining the benefit of treating your depressive symptoms in the moment, but you're building tools to help you treat it in the future. For example, one thing in cognitive behavioral therapy is what's called a thought log, where you might say, you might have a negative thought, and then you have to think of three things that counteract it. So I might be feeling depressed, and I might say, man, none of my friends are ever there for me when I need them. Nobody cares about me. But then I might have to think of three things that contradict that. Well, okay, this morning my friend texted me and said, hey, it's been a while. I just wanted to check on you to see how you've been. A couple months ago, my friends planned a surprise Zoom party for me. Let's see what else. My a friend who I loaned money to like 2 years ago finally like paid me back and sent me like a really nice card and like additional gift. So people actually do care about me. People do respect me, right? If I'm practicing that for the rest of the year, then 2 years later, if I have the feeling of nobody cares about me, then I'm going to remember that people do care about me. It's going to be a little bit easier for me to recall those things. So cognitive behavioral therapy is great because the effects can be long lasting. Exercise also has a modest antidepressive benefit. So it's also great as a supplement to other treatments. Getting out, using your body, it stimulates your brain. It forces you to break through that like feeling of withdrawal. So sometimes that's referred to as behavioral activation. One tip that I do when I'm feeling very stressed is I just find little things that I can do, right? So if you're feeling very stressed, if you're feeling depressed, it feels like everything is overwhelming. And so I just challenge myself if I'm feeling very stressed to do one small thing. So is it clear out my junk mail or, wash 3 cups? There are 3 cups that need to be washed. They're in the sink. Can I wash 3 cups today, right? Can I walk around the block once? What is there some little thing that I can do just so I can feel that like little bit of dopamine that makes me feel a little bit better? And then from there, I can go, I did one thing. Do I have the energy to do more things, right? If I don't, I can feel good that I did one thing. And if I do, I can do more things. So exercise, getting active is good for your brain. Also, having a healthy diet, right? A healthy diet, as we've started to talk about like the connection between the body and the brain, we understand that you need to get your brain the fuel that it needs, right? So omega-3 fatty acids, B vitamins, things like that we know are good for your brain health. Now, the amount of those is not conclusive, and it's probably going to be a while before we really know. So don't just, go buy a whole bunch of omega-3 pills and B vitamin pills, and that's going to be the cure for your depression. But be aware of your diet, be aware of what you're putting into your body, right? It doesn't have to be health, health, health all the time, but make sure that it's balanced, right? If you haven't had a vegetable in 3 years, try one. I've heard that they're really good. In addition to CBT and antidepressants and exercise and diet, there's also ECT, electroconvulsive therapy, which is an electrically induced seizure, which is only used for severe depression. So this is only for patients who've responded to nothing else, right? You don't want to just jump into this because you are inducing a seizure, which, just in case you didn't know, you definitely don't want to just do that willy nilly in the brain. One of the side effects includes memory impairment. This can be minimized when you only focus the treatment on the right hemisphere of the brain, but there is still a high risk of relapse of depression without continued treatment. We don't really understand necessarily why it works. We're assuming that the shock and the seizure helps proliferate neurons in the hippocampus and increases the BDNF, but it's still something that we don't fully understand. So, if you're not reading along with the PowerPoint, the fun note about this one is contrary to in the past, nowadays ECT is given with muscle relaxants or sedatives in order to reduce the pain, which is funny because back in the day they're like, let's shock this person's brain. Do we need to give them any pain relievers? Nah, they'll be fine. It's just electricity surging through their brain. Who needs that, right? Oh boy. Sometimes you look at the history of science and you just go, this should have been common sense. Yeah, it's fine. It's fine. So as you might know from the fact that I mentioned it a little while ago, depression can alter your sleep. Disruption of sleep patterns is common in depression. Sometimes you need more sleep than usual. Sometimes you're having trouble getting as much sleep. So some people with depression will fall asleep but awaken early and are able to or unable to get back to sleep. This is what is called insomnia. So I can feel you guys falling asleep. But don't worry, if you have insomnia, you'll wake back up in like 10 slides and you won't be able to fall back asleep. So, perfect. So, people with depression will also enter REM sleep sooner than normal. So, they won't get enough of that really deep sleep. The so sleep pattern disruption will increase the likelihood of depression later on. Studies on sleep and depression are very fun because we can see that the two things are related, but the question is what thing causes the other? So, is it because you're experiencing sleep disturbances that you're getting depressed? Or is it because you are depressed that you are experiencing sleep disorders? Or are they two related things that exacerbate one another, right? So you start to have depression and then it affects your sleep. But because you're tired, you're more depressed. And because you're more depressed, you get worse sleep, right? So really understanding the directionality of that relationship is one of the big issues when trying to understand sleep and depression. So sometimes periodic sleep deprivation can help. So the we're seeing that our disrupted circadian rhythms are playing a role in depression. So seasonal affective disorder is a disorder in which some usually during a specific time of the year you'll feel depressed, but not during the rest of the year. So it's very common to experience that during the winter months. There are a lot of reasons for that. It's colder, less sunlight, and also all the holidays happen. So for a lot of people who've experienced the death of a loved one, you tend to miss them more around that time. But the aside from the social aspects of it, that biological like awareness of seasons and how it's tied to our depression might be an indicator of what's happening biologically when we're looking at depression. So it might be tied to our body's natural rhythm. So our body temperatures are related to that process of homeostasis, and it fluctuates in sleep. Part of those changes help our body know that it's time to fall asleep, and they help with the sleep process. You can see that it is a slightly shifted schedule for people who are depressed. So the other thing to note is this pattern going from stage one to stage four back up to REM sleep. Normal people, non depressed people, are having much more time in stage four sleep. But we're seeing less time in depressed people. Also, similarly, we're seeing less time in normal people who go to sleep late. So, get to bed on time, then because you have school or work in the morning. So, seasonal affective disorder, SAD, it's, as mentioned before, a form of depression that occurs during a particular season, such as winter. It is more prominent if you live closer to the poles. So if you're near the equator, I almost said near the equator, which technically about the same thing. But if you're near the equator, then you're not dealing with drastic seasonal changes. The closer you get to the poles, the more you're going to deal with those seasonal changes. So if you have seasonal affective disorder, you tend to have a phase delayed sleep pattern and sleep rhythms, but most depressed people have phase advanced patterns. So if you were to look at a somnogram, you would be able to see the difference between somebody who is depressed versus somebody who has seasonal affective disorder. So treatment for seasonal affective disorder often uses very bright lights used for 1 hour or more daily. Uh, you might have also seen personal lights that you can buy to help with seasonal affective disorder. Benefits, we don't fully understand them, but they are substantial, so they are worth looking into. Uh, it could just be because it's signaling the brain that it's like, oh, no, this is, I guess it's summer, not winter, because I'm looking at this bright light all of a sudden, right? Now, people with seasonal affective disorder do have a mutation on the gene that's responsible for regulating circadian rhythms, so we can see that there is a genetic root to the disorder. So here we go. We have seasonal affective disorder, that is phase delayed. We have depressed people, phase advanced, and we have people who are not depressed or don't have seasonal affective disorder, who have a normal circadian rhythm. Another technique is deep brain stimulation, which implants, you're implanting a battery powered device into the brain, which delivers periodic stimulation, which is the same kind of stimulation that you might see as a result of using an antidepressant drug. So it's just instead of doing it with a drug, you're doing it with a device. It's still in an experimental stage, so you can't just like go to CVS and get one of these real quick, but the results are encouraging. An alternative is what's called optogenic stimulation, where you're basically uh, manipulating cells to make them sensitive to light treatment, which allows you to specifically stimulate certain cells, which will trigger stimulation in the areas that you are trying to stimulate. So, in addition to depression, we also have what is called bipolar disorder. So, unipolar depression, we go from states of normality or normality, uh, and and depression. So, you have times when you're feeling okay, and then you have times when you're feeling depressed. Bipolar disorder, which used to be called manic depressive disorder, is when you're going from manic to depressive. So we are familiar with depression, but mania is the opposite. So you're feeling restless, you're excited, there's a lot of laughter, very high self confidence. Sometimes you'll see rambling speech and loss of inhibition. So it's basically the best, you're feeling as good as you can possibly feel, far in excess of normal happiness. So there are two types of bipolar disorder, bipolar 1 and bipolar 2. You meet the criteria for bipolar 1 disorder if you have just a manic episode. Bipolar 2, there's no mania. There's a less severe version of mania, which is called hypomania. If you see hypo, that means below, so it's below mania. So if you've ever gotten a shot, you've gotten that with a hypodermic needle because it goes under the dermis or the skin. If you're experiencing hypothermia, your temperature is below what is considered normal. So hypomania is mania that's less severe. It's more mild than normal mania. For bipolar 2, you need to have hypomania and depression. The normal onset for bipolar is in teenage years or the early 20s. So when people are, in high school or entering college. During manic episodes, your brain's use of glucose increases, so it's burning through that brain fuel. And during depression, your brain is using less glucose. So here are some PET scans for a patient with bipolar 2. These are the depressed states. This is a hypomanic state. So you can see that during the depressed states, there wasn't as much brain activity. That's less than what you would normally see in the brain. But during the hypomanic state, the brain is burning through that glucose, right? There's a lot of activation in the brain. So there are drug treatments for bipolar disorder. A common treatment is lithium, which is a mood stabilizer. The great thing about lithium is that it helps balance out those extremes, so it prevents relapse to mania or depression. There are other drugs like Depakote and carbamazepine, and these drugs work by decreasing glutamate activity. They also block the synthesis of the brain chemical arachidonic acid, which is produced during brain inflammation. Yep, that's it. I thought I was going to say more, but I had nothing more to say. I'm done. Arachidonic acid is that's it. That's it. That's all for this slide. So now we're moving into schizophrenia. So schizophrenia, in addition to the psychotic symptoms that we'll talk about, uh, one of the big issues with schizophrenia is this deteriorating ability to function in everyday life. So schizophrenia isn't diagnosed until the symptoms have lasted for at least 6 months. If it's a period of 1 to 6 months, it's schizophreniform disorder. If it's less than a month, it is brief psychotic disorder. But in addition to that deteriorating ability to function, you need to have some of the following symptoms. Hallucinations. The book says hearing voices, but hallucinations can be any sensory stimulus. So some hallucinations can be auditory, so hearing voices. They can be visual, or they can be sensory. They could be tactile, right? Maybe feel things that aren't actually there. In some rare cases, they could be olfactory or gustatory, so they can affect your taste or smell. Then we have delusions, which are unjustifiable beliefs. They can be paranoid delusions. They can be persecutory delusions, so somebody's out to get you. They can be bizarre or romantic or jealous. These beliefs that people have about the world that are not true. You'll often see disorganized speech. So it might be hard to understand what people are saying. Sometimes you'll hear about word salad. So people will say things and, the uh, white kayak, orange juice, rock star, computer fart. Right, that would be word salad, where I'm obviously saying something, but I can't get the correct words out. If you remember Wernicke's aphasia, right, the speech is still expressive, but sometimes they can't get the right words. That's a similar issue with speech. Their behavior is also going to be disorganized. You're often going to see that they have a hard time taking care of themselves. And you might also see what's called flat affect. So they might be talking about something very emotional without having any expression of that emotion, either in their tone or on their face. And there might be limitations to speech and lack of interest in socialization. When talking about schizophrenia, we split the symptoms into positive symptoms and negative symptoms. Positive symptoms are things that are present that shouldn't be there. So they're adding things. Negative symptoms are things that should be there but are now gone or disorganized. So positive symptoms are things like hallucinations, delusions, disorganized speech, and disorganized behavior. Negative symptoms are things like flat affect, that weakened emotion, lack of speech, lack of interest in doing things, lack of socialization. So negative symptoms tend to be stable over time, and they tend to sometimes be difficult to treat. There are also cognitive symptoms. So in schizophrenia, you often see limitations of thought and reasoning. So sometimes thinking can be very tangential. It's hard to follow the course of what they're saying. So I might be talking about how I was drawing a picture the other day of a horse, and all these people were like yelling and protesting and talking about like how angry they are, and like there was a fire, and everybody was like mad at me, and I told them like, mom, like I'm trying my best right now, I'm trying my best, mom, right? So they were doing an activity, but then now they're talking about something, and it seems like they're talking about the protest, but now something's happening with their mom. Is that related, right? So that tangential thinking is very common. Also, reasoning can be impaired. So you might see impaired reasoning. So, especially when it comes to very abstract concepts, it's going to be much more difficult. One hypothesis for this is due to impairments in attention and working memory. If you think about like telling a story, when you're telling a story, you're thinking about the things that you just said, you're checking in with other people to see their reactions. You're in the process of saying what you're actually saying now, and you're thinking about what you're going to say next. The fun thing about that was I was doing what I was doing as I was talking about doing it, which I realized I was doing halfway through doing it, and then I planned to point out the fact that I was going to say that. And now that I've said that, I don't know what comes next, right? But in order for me to have that beginning, middle, end, I'm focusing on what's happening. I'm remembering what just happened, and I'm attending to what's going to need to happen next. So that's a function of my working memory and my attention. If my memory is impaired in any way, then it's going to be very hard for me to keep track of what I'm saying and what the progress is. So it's very important to note that like the importance of our attention and working memory in reasoning and in speech. So any impairments to that are likely going to result in the symptoms that we see in schizophrenia. So, one important thing to do when you are diagnosing mental illness is what's called a differential diagnosis or a rule out. So, there are things that can look similar. So, for example, in mania, you can have psychotic symptoms. So, bipolar 1 in some cases can look very similar to schizophrenia. So, as a psychologist or a doctor, you want to make sure that you rule out things that could look similar. So we never want to rush to diagnosis. If you ever have a side conversation with me about somebody's symptoms, one, because I'm not a licensed psychologist, I'll never give a diagnosis. I'll never say, oh, they definitely have this. I'll say, it sounds like it could be this, but because I don't have the ability to look at their whole medical history and do a clinical interview, I might say, these are some things that it sounds like, but you'd want to get them to a professional because a professional is going to rule out everything. So when it comes to schizophrenia, there are other things that can resemble it. Substance abuse, right? If I'm high on meth, or if I am doing some hallucinogenic drug, right? I might hear voices, I might see things, I might be afraid that somebody's out to get me. I had a friend who, when he smoked weed for the first time, was very paranoid and very scared, and had a very bad experience. If I'm meeting this person for the first time, I'm going to assume that they're schizophrenic, right? Not me, because I would do my differential diagnosis. But one might assume, oh, this person's psychotic. But drug-induced psychosis is different than actual schizophrenia. We also want to look at brain damage. So if certain functions of the brain are being damaged, then we can see symptoms that look very much like schizophrenia. Undetected hearing deficits could result in people feeling like they're hearing things that aren't actually there. So that's an auditory processing disorder. Huntington's disease, nutritional abnormalities. There are lots of things that can look like schizophrenia, but not be schizophrenia. So you want to be aware of that and rule those things out. So half of 1% of the worldwide population deals with schizophrenia. So relatively common-ish. The so That was a weird ish. Sorry about that. Ish. It's more common for men than women, but it does occur in all ethnic groups in all parts of the world. So there are some disorders that have a strong cultural bias. So, for example, eating disorders, that's a very Western culture thing. In the global South, South America, Africa, you're not seeing eating disorders be as common as you would see in America, Europe, those types of countries. Uh, there are a lot of mysteries about schizophrenia. Why is it linked to colon cancer and certain autoimmune diseases? There's transferrin methyl 2 hexanoic acid, which is uh, part of the characteristic body odor of schizophrenia. So you can actually smell schizophrenia, which is really interesting to think about. The smells are a thing that's so important to our experience of the world, but not something that's like really studied as much. But that is something that someone did study, so and found the chemical root of. Why is there a distinctive smell, right? Then there's also a difference in the presentation of schizophrenia in women versus men. So women tend to have more affective symptoms, while men tend to show more negative symptoms. There are also issues in pursuit eye movements. So if I showed you like a pen and I put it in front of your face and I told you to follow it with your eyes, I'm doing it right now. Uh, Most of us can do that very smoothly, right? If you are drunk, then you have a much harder time doing it. If you are having trouble doing it right now, you are drunk. Congratulations. Now, those deficits also are present in schizophrenia. What about schizophrenia is tied to our eye movements, right? Uh, who knows? The there are a lot of things that we just don't understand about the disorder, which is exciting because if you are interested in schizophrenia and you want to understand more, you can become a researcher. I believe in you. So we got to talk about genes. Research suggests a genetic component, but it's not just one gene like a lot of the things that we've talked about. Monozygotic twins have a much higher rate of showing, both twins showing schizophrenia than dizygotic twins, but it's only a 50% chance. So if you have a twin and they have schizophrenia, flip a coin and that'll determine whether or not you have schizophrenia. But one interesting thing is there is a greater similarity between dizygotic twins than siblings, meaning that something about being in the same prenatal, postnatal situation might have an effect on the development of schizophrenia. So here we have some stats on concordance. So if you're part of the general population, nobody that you know has schizophrenia, 1% chance. If you are the husband or wife of somebody with schizophrenia, 2% chance. That's Really interesting, right? No blood relationship, but still it increases your chances. So it's probably not a causal relationship. There might be other factors at play, but 2%. If you are cousins with somebody with schizophrenia, 2%. Same with uncles and aunts, nieces and nephews and grandchildren, half siblings, 6%. Your children, 13%. So children of schizophrenic mothers adopted by non-schizophrenic mothers, 17%. Siblings, 9%. Dizygotic twins, 17%. Parents, 6%. Monozygotic twins, 48%. Children of two schizophrenic parents, 46%. So genetics do seem to play a role, but also environment has a effect as well. So genes do have an influence, but as we'll see on the chart on the next page, environment also influences your likelihood to develop schizophrenia. So blue, people with genetic risk; red, people with no genetic risk. So if you have the genes for it, then on average, you're more likely than somebody who doesn't to develop schizophrenia, right? We can see that difference. Now, if the family that adopts you is normal, well, there's a pretty low risk that you're going to develop schizophrenia, less than 10%. But moderate dysfunction in the family. So this is above just like, you got grounded once and then you were really upset and he said, "I hate you, mom." And then your mom was like, "I hate you too." And then you like apologize and then you're stronger for it, right? That's normal. We're talking moderately dysfunctional. That genetic risk gets exacerbated. So it's a very slight increase for no genetic risk. But once there's that environmental aspect to it, that pops up significantly to almost 25%, but above 20%. When it's severely dysfunctional, it still increases the risk for no genetic risk, right? Almost fully to 10%. But for people with a genetic risk, it's really dangerous, right? So we can see that there's this relationship between your genes and your environment. No environment with genetic risk, or normal environment with a genetic risk, you're pretty unlikely to develop schizophrenia. But once your environment gets dysfunctional, and if you have the genes for it, it's very likely. So we've tried to find the gene because when we understand what genes are responsible for things, we understand the thing even more. But a lot of the genes that are common in people with schizophrenia are also common in people without. So we might find something, but it's hard to replicate those results. So what is possible is that there is a gene that's responsible, but it's occurring, or the rate of schizophrenia is due to either mutations on the gene or microdeletion of chromosomes. So it's not the actual genetic code originally, it's more so what's happening to the genes over time. Let's talk about the neurodevelopmental hypothesis. So, things that occur when you are young and your brain is developing, especially before you're born, any abnormalities can have long lasting effects. It can leave your brain vulnerable to anything that could happen later. So, it's very important that at a very early stage, when your brain is most vulnerable, that we keep it safe. And a thing to keep in mind is that small abnormalities in your brain anatomy early on can lead to major abnormalities in your behavior later on. So when looking at schizophrenia, we can see that there are some prenatal or neonatal difficulties that are linked to later schizophrenia. So we can identify specific behaviors and go, well, because we're seeing this, it's very likely that this is going to lead to schizophrenia later in life. And we can actually see differences in the shape of the brain because it has developed abnormally. So these early developmental abnormalities, as we've mentioned before, are going to impair behavior later in adulthood. So there are some big risk factors and little risk factors. So living in a crowded city increases your risk, more pollution, more exposure to stressors. Also, Toxoplasma gondii, which is a parasite that hangs out with cats. So it can be found in their feces. So if you are pregnant or immunocompromised, you should not handle cat litter. So if you have cats and you're living with other people, and you just happen to be pregnant or immunocompromised, just go, sorry, can't handle the cat's poopy because of Toxoplasma gondii. Some ways of reducing the risk of getting it are limiting your cat's exposure to the outside, so making sure that they stay an indoor cat and making sure that you're only feeding them food that comes from either like actual cat food or food that's been carefully prepared at home. So, as much fun as it is to let your cats bring in dead bugs and mice and birds to show you how good of a hunter they are, those could carry parasites. So, some lower risk factors are poor maternal nutrition, premature or low birth weight, complications during delivery, head injuries in early childhood, and extreme stress or illness of the mother during pregnancy. More than likely, one of those by itself isn't going to lead to a schizophrenic child. Those with other things in addition could contribute. So another fun thing, blood type, which is something that we don't really think about too much, but if a mother has Rh negative blood type and the baby is Rh positive, so for example, the mother was A negative, but the baby was A positive, the child has a about twice the probability of developing schizophrenia. So this response is actually weaker in the first child, but stronger in later pregnancies, especially for boys. The reason for this is the mother's body will sometimes identify the child as a foreign object. When there's something foreign in your body creates antibodies. So this can also be an issue with boys because boys have testosterone more so than the woman's body is used to, so there might be antibodies created against testosterone. So that Rh that's positive, the mother's body goes, this shouldn't be here. Let's be careful with this one. Also, weirdly enough, the season in which you were born seems to have a slight effect, 5 to 7%, on the probability of developing schizophrenia. So, if you're born in the winter, you are more likely to. This is more pronounced the further you are from the equator, because the further you are from the equator, the more seasons you actually experience. Right at the equator, it's just summer. It's just summer and then slightly less summer and then more summer. But one explanation for this is because of the seasonality of illnesses like the flu. So that increases the chance that the mother might be exposed to an illness while carrying the child. Also, as soon as I said carrying the child, I immediately thought of Baby Yoda. So just yeah, if you're feeling stressed, just think about what would Baby Yoda do right now. And yes, I know that it's not an actual young Yoda. I don't want to have this Like we're just going to call it Baby Yoda, and we just have to be okay with that. So if the mother is dealing with a viral infection, then more cytokines are going to be released in the body. These are signaling to the immune system to act, which could negatively affect the brain development of the fetus. Also, if the mother has a fever, then that's going to slow the divisions of fetal neurons, right? This is a very important stage of development, and development is happening rapidly to get to the point where the child is ready to be popped out into the beautiful world that's full of optimism and joy. And anything that's slowing that down is going to cause problems. So, in conclusion, there are a lot of genetic and environmental influences that can cause schizophrenia. One thing by itself, you'll probably be okay. Multiple things can definitely add up and increase your risk of developing schizophrenia. So when we're looking at the brain abnormalities, you're going to see in schizophrenia less gray matter and white matter, so smaller brain mass overall, larger than average ventricles, so smaller brain, but larger ventricles as opposed to the brain that normally looks like this with very small ventricles. That's my very good drawing of the brain. I hope it's your favorite drawing of the brain that you've ever had. Minor abnormalities in subcortical areas. So we lift up this top part of the brain, very good brain, and then all these areas under the cortices. Your amygdala and your hippocampus and your thalamus and your hypothalamus. Also, a smaller hippocampus. You'll also see the deficiencies in memory and attention, which are consistent with damage in the prefrontal cortex. So even though the prefrontal cortex hasn't been like hit, right, you're still seeing similar deficiencies like you would see if somebody had that damage. So there are some other brain abnormalities. So here's our really well drawn brain, and right around here, that looks like a manatee, not a brain, but it's fine. I'm good at other things like um, saying words. But right here in the right planum temporal, it's slightly larger in people with schizophrenia. Interestingly enough, right around here is also Wernicke's area. So they also have lower than normal activity in the left hemisphere, and they are more likely to be left-handed. So here we have two identical twins. Looking at the ventricles, can you see which twin has schizophrenia? No, I'm just kidding. It's not this one. It's this one. You can see that the larger ventricles are right there in comparison to these right here. So that is one of the things that you'll see in schizophrenia. So here is a monkey brain, and this monkey, as an infant, was damaged in their dorsolateral prefrontal cortex, right there. Uh, the interesting thing is, at 1 year of age, there's not really any effect of the lesion. They are performing just as well as, or almost just as well as other undamaged monkey will do. But around age 2, the effects of that lesion are more apparent. So they're performing significantly worse than undamaged monkeys would. So what this shows us is sometimes brain damage can, or any changes in the brain, might for a few years go unnoticed until enough time passes and we can really see the significant impairment caused by that damage. So schizophrenia was previously thought to be a progressive disorder, so slowly getting worse. But Now we understand that it can be varied in its course. So maybe at this point somebody starts getting treatment, and then over time they get back to normal, something like that, right? So the thing that we understand is that external factors throughout the lifespan can have an effect on the course of the illness. So, poverty, social support, drug abuse, and other factors can influence outcome. So, maybe at 25, you're starting to get better, but at 26, there's a major life stressor, right, that could worsen your symptoms. So most cases of schizophrenia are not diagnosed until the age of 20 or later, but we can often see some issues in childhood with impulse control, attention, and memory, meaning that it could be confused for ADHD early on. So when we talk about differential diagnoses, right, it's very important to watch out for things that can look like other things. The dorsolateral prefrontal cortex is one of the slowest brain areas to mature. Your prefrontal cortex doesn't fully mature until the age of 25, but that area will show consistent signs of deficiencies in schizophrenia patients. So let's talk about some of the treatments. We have thorazine, which is used to treat schizophrenia, and it relieves a lot of the positive symptoms, so the hallucinations and the delusions. And we have the class of antipsychotic or neuroleptic drugs, which are used to help relieve schizophrenia and also similar conditions. So sometimes it can be used to treat something like a manic episode in bipolar 1. There are two chemical families of antipsychotic drugs used to treat schizophrenia. We have your phenothiazines and your butyrophenones. Woo! I was worried that I was going to mess one of those up, but I did it. Dab, dab, dab. So now you try it. Phenothiazine and butyrophenomenal. Got it. So both of those block dopamine synapses. And just for fun, here we can see the effectiveness of different types of drug. These are the most effective ones over here. These are the least effective ones. Pick your favorite. What's your favorite? Mine, benperidol. I know some of you guys are those Mullen types, but you know, whatever you like, that's fine. As long as it's not thiothixane. I'll never understand people who like thiothixane. So one hypothesis is the dopamine hypothesis of schizophrenia, which is that schizophrenia results from excess activity of dopamine synapses in certain areas in the brain. So, one thing that can happen is a substance induced psychotic disorder. So, you might have hallucinations or delusions resulting from large doses of amphetamines, meth, or cocaine, because all of these prolong activity at your dopamine synapses. So, if these drugs prolong activity at dopamine synapses and create symptoms that are similar to schizophrenia, those hallucinations and delusions, then we can assume that dopamine is related to the symptoms of schizophrenia. So research does indicate more activity specifically at the D2 receptor. Interestingly enough, schizophrenics have twice as many D2 receptors occupied as normal. So they have two D2 receptors. Uh, that's dumb. That's a dumb joke. I'm so sorry. I'm very sorry for that. I'm not going to delete this. I'm not going to, you know, if I made the mistake, you have to deal with the consequences of me making that mistake. So just remember 2D2, and you can be mad at me if you want. I'll take it. I will take all your anger for that pun. So let's talk about the mesolimbo cortical system. That is a hard word to say when you are tired. Mesolimbocortical system, mesolimbocortical system. It is a set of neurons that project from your midbrain tegmentum to the limbic system and your prefrontal cortex. This is where the drugs are blocking the dopamine synapses that produce these benefits that treat schizophrenia. Now, drugs will also block dopamine in the mesostriatal system, which results in what's called tardive dyskinesia. So Parkinson's occurs when your brain isn't creating enough dopamine. Schizophrenia, we're assuming, is related to too much dopamine. So tardive dyskinesia, these tremors and involuntary movements, look very similar to Parkinson's disease because we're seeing basically the same thing that would happen in the brain under Parkinson's. So just so you know, tardive refers to a slowing of, kinesia, movement, and then think disorganized, right? So slowing and disorganized movement. So here's our mesolimbic cortical system going to our prefrontal cortex. And here's our ventral tegmental area. Here's our substantia nigra hanging out, making dopamine. And then we have our mesostriatal system. So atypical antipsychotics, so a class of second generation antipsychotics, they are newer. They're great because they seldom produce movement problems, so you're not going to see tardive dyskinesia. So clozapine, amisulpride, risperidone, those are some examples. Part of what makes them great is they have less of an effect on those dopamine D2 receptors, but they are antagonizing serotonin receptors. So they're blocking those serotonin receptors. So those serotonin is like, oh, I guess it's closed today. Not going to hang out and bind to some receptor sites. So some of the side effects of the second generation antipsychotics are weight gain and immune system impairment. Unfortunately, they don't increase quality of life more so than the other drugs. So unfortunately, people with schizophrenia, even if they're taking these second generation antipsychotics, might still be severely impaired. So to summarize, we can't just explain schizophrenia by the function of one gene or one neurotransmitter. It is a very complex disorder in the brain. So these are scans of a patient with schizophrenia. In this scan, they were taking clozapine. In this one, they were not. So we can see that the drug helped increase activity in the brain. So we also have the glutamate hypothesis. So one problem with schizophrenia is that there is lower activity at glutamate synapses, especially in the prefrontal cortex. So dopamine inhibits the release of glutamate. Also, glutamate stimulates neurons that inhibit dopamine release. So these two are constantly at war with each other. So increasing dopamine can produce the same effects as decreasing glutamate. So more support comes from our old friend PCP, angel dust. It inhibits the NMDA glutamate receptors. In larger doses, it's going to produce both the positive and negative symptoms of schizophrenia. So it helps us kind of understand schizophrenia, both PCP and ketamine, which we also talked about previously when we were talking about depression, don't really produce much of a psychotic response in pre-adolescence or preteens. So the symptoms of schizophrenia usually emerge after puberty, and in the same way, the psychotic effects of PCP do. So if you remember being in fifth grade and doing angel dust and going, I don't feel anything, while all of your 20 and 30-year-old friends were like tripping, and you're like, what's wrong with me? Well, one, you shouldn't have had 20 and 30-year-old friends. That's not a healthy childhood. But two, your brain would respond to the drug differently. So also, taking PCP can produce a relapse for somebody who's already recovered from schizophrenia. So it's recreating those issues in the brain. So finally, we have autism spectrum disorder. Uh, Autism used to be separated into autism disorder, Asperger's syndrome, Rett's disorder, and a few other ones that you probably haven't heard of. They're so rarely talked about that I don't even remember what they're called. But we lumped them all together because we saw that there were commonalities in all of them, and they actually aren't separate diagnoses. They represent a variety of functionings across a spectrum. So that's why it's called the autism spectrum disorder. So, as mentioned, it includes people with varying degrees of difficulty, from mild to severe. It used to not be diagnosed as much, but it is more commonly diagnosed today because we're more aware that it is a thing. So, back in the day, unfortunately, when people were dealing with mental illness, it was often ignored or they were just treated as a weird kid, and we didn't realize that there were treatment methods that could lessen the severity of their symptoms. So, part of the reason that it is diagnosed more today is because we are more socially aware of it. So, we see the symptoms and we know what to name it. We don't just say, oh, well, he's real interested in stuff and he doesn't like socializing. We're like, oh, that's probably autism spectrum disorder. So also it is more commonly diagnosed in boys than in girls. And I feel like I shouldn't have to say this, but just real quick PSA, vaccinations don't cause autism. Vaccinations don't cause autism. Vaccinations don't cause autism. Once more, vaccinations don't cause autism. So some of the characteristics that we might see are deficiencies in socialization and emotional exchange. So there are just certain things that we do normally when we speak to people. So for example, let's say somebody called my name, right? Immediately what I do when I hear my name is I turn to the direction of the sound, right? If somebody's talking to me, I'll look in their direction. We tend to make eye contact. The degree to which we make eye contact is a little bit determined by our culture, but we look in their general direction and maybe look at their nose or mouth as they're talking. And those types of things are part of our normal social development. As well as like emotions and like understanding people's emotions and reacting appropriately. We might also see deficiencies in nonverbal communication, so facial expressions, gestures, right? If somebody is talking to you and they're like, "Yeah, this week has been really hard. A friend of mine just died." Immediately, your face goes, oh no, right? You can probably imagine what my face did as I was trying to convey that. So those types of things are going to be deficient. You might not see that same level of automatic gesticulation or facial expression. There might be repetitive movements, especially in younger children, so flapping, those types of things. And they're very resistant to changes in routines because things have to be done a specific way, and there are often unusually weak or strong responses to stimuli. So, being much more sensitive to something or not being bothered by something. So, an example of this is usually when like a fire truck passes by, everybody like covers their ears, right? Maybe they don't seem to be bothered by it. That would be an unusually weak response to stimuli. Also, as I said that example, like whenever fire trucks pass by, I'm not bothered by the sound. don't diagnose yourself. That's always a terrible thing to do. So infants with autism will make a normal amount of eye contact around up to about 2 months, but that interest in making eye contact will decline over time. So there are some genes linked to autism, but like everything else, there's no one gene that's found in a high percentage of people with autism, meaning that there's no clear like autism gene where you point to it and you're like, that's what the autism gene is. Many cases, just like schizophrenia, may result from mutations or microdeletions in one or more genes. Some mothers of children with autism might have antibodies that attack certain brain proteins. So we've talked about how sometimes the mother's body might look at the developing child and say, "This is what's this doing in here? What is this little weird growth that's going on? And why is it so cute? Let's attack it." Studies in monkeys have confirmed that this is a contributing factor. So we can see these antibodies being developed that are attacking brain proteins. Prenatal nutrition is another thing. So adequate amounts of folic acid during pregnancy basically halves the risk of having an autistic child. So if you get nothing else from this class, healthy diet, exercise, so good for your mental health. And if you happen to be a mother, great for the mental health of your developing child. So take care of yourself. Eat a sandwich. Are sandwiches healthy? I don't know. I'm not a nutritionist. So, as far as treatments for autism spectrum disorder, there aren't any medical treatments for these central problems, the social behavior and communication. Risperidone is sometimes prescribed, and it reduces some of these stereotype behaviors, especially if they're engaging in behaviors that are harmful. So, if they're, smacking their head into things, that you're weighing the risk of the medicine and the potential side effects, which can be very serious with the reduction of harm to themselves. So when you're looking at treatment, you're often looking at behavioral treatment. ABA is the one that you will hear about all the time, and these focus on attention to and reinforcing favorable behaviors. So we're not trying to fix the problematic ones, we're trying to reinforce the good ones. So that's it. That's the last slide. We did it. We survived the entire semester. All you got now is a final exam. And you know what you've done before in this class? 3 exams. So I have no doubt that you will kick this exam's tush. I wasn't sure if I could say the A word because, you can't just say that word. It's terrible. That would be asinine. See, I can say it if it's part of another word. Or I could talk about my favorite type of guitar, which is a bass guitar. Bass guitar? Yeah, it's a bass guitar. Bass is the fish, bass is the guitar. Anyway, you're going to kick this test's bass fish. Have a wonderful rest of your whatever time you're listening to this lecture. Take care of yourselves. Thank you for a wonderful semester. Talk soon.